This is a podcast on basics of neuromuscular blocking agents. As a background to these class of drugs, it's important to remember that the components of general anesthesia, unconsciousness, amnesia, analgesia, autonomic control, and immobility, all of those really aren't met except immobility when giving a neuromuscular blocking agent. And that's an important thing to remember. Depolarizing neuromuscular blockers, such as succinylcholine, which is the only clinical one in use today, act as acetylcholine receptor agonists, while non-depolarizing NMBD'S, neuromuscular blocking drugs, act as competitive antagonists at the nicotinic receptor on the muscle. The choice of these drugs is influenced by those characteristics, a whole host of characteristics, some of which are listed on the slide there. Basic physiology by way of a quick background. The transmission of a signal travels down the axon, reaches the motor nerve plate, causing an influx of calcium and release of acetylcholine, which then transfers across the synapse, binding to the postjunctional nicotinic cholinergic receptors. Causing a mini M plate potential. When enough of these mini M plate potentials reach threshold, then an action potential is propagated along the surface of the skeletal muscle, causing contraction. This acetylcholine is rapidly hydrolyzed by true cholinesterase, which sits deeper in the folds of the muscle membrane, of the muscle end plate. And again, neuromuscular blocking drugs are structurally similar to acetylcholine, particularly the depolarizing muscle relaxant succinylcholine. A couple of important things from a pharmacodynamic standpoint regarding the cholinergic receptors. They are, of course, nicotinic as opposed to muscarinic, which sits other places in the body, most prominently on the heart, which we are probably most concerned about. They can be, most importantly, postjunctional. They also, in terms of regulating acetylcholine, there are some prejunctional receptors, and then a number of extrajunctional receptors can form over days and typically proliferate with inactivity, sepsis, types of denervation, trauma, or burns, certainly after 1 or 2 days. And these extrajunctional receptors can respond in an exaggerated way to succinylcholine, causing hyperkalemia. Here's a cartoon relaying, repeating some of the important anatomical considerations in the propagation of a skeletal muscle contraction. The signal comes down the axon. Calcium moves into the cell, and the acetylcholine is released, diffuses across the membrane, combining to these acetylcholine receptors. Deeper on into the folds, acetylcholine esterase is chewing up that acetylcholine. But if enough of it binds to the receptor, the skeletal muscle depolarizes and contraction occurs. Here is a table out of an earlier edition of Morgan and McCall. Many of these drugs are listed in all editions of basic texts. Recognize that succinylcholine is the only clinically important depolarizing muscle relaxant that we'll consider. And of the non-depolarizing muscle relaxants, a number of these are no longer made or no longer utilized in the United States, among them most prominently curare or tubocurarine. But there are a number of longer-acting ones, of which we are most familiar with Pancuronium or Pavilon. Intermediate-acting ones, Cisatracurium was a precursor to the cis isomer, which has important improvements or distinctions from Cisatracurium. So we're familiar with Cisatracurium, Mivacurium, Rocuronium, and then these two short-acting neuromuscular blockers, non-depolarizers, are here for historical interest mostly, and we'll talk about them briefly as well. So neuromuscular blocking drugs, and this is in particular reference to the depolarizing neuromuscular blocking drugs, of which I said succinylcholine is the only one that's clinically used. If you look at the structure of succinylcholine, it's two joined acetylcholine molecules. It causes a depolarizing block, so it binds to the receptor, causing a partial, if you will, depolarization of that muscle membrane, which then goes into a brief paralyzed state through its conformational change, which is termed a phase 1 block. The dose is listed there. You will, because of this depolarizing block, see fasciculations in most patients to which you give this drug. It's thought that perhaps these fasciculations may be in part responsible for the myalgias that you will sometimes see in ambulatory surgical patients. These fasciculations can be blunted with pretreatment of 5 to 10% of an ED95 dose of non-depolarizing neuromuscular blocking drug. When the dose of succinylcholine is much higher, 2 to 3 times its usual induction dose, a phase 2 block can occur. This is a block in which a different type of conformational change occurs in the drug-receptor interaction, such that the receptor goes into a more prolonged paralyzed state. It's oftentimes referred to as a desensitization blockade. So this post-junctional receptor can repolarize, but it's unable to respond to further acetylcholine. These blocks most typically mimic non-depolarizing blocks in their characteristic. So let's look briefly at some of those characteristics of depolarizing versus non-depolarizing NMBDs. We see that a couple of the more important things, that when you use a train of 4 and to monitor your response to these NMBDs, what the ratio would look like with 4 stimulations in a phase 1 succinylcholine block versus a phase 2 depolarizing block when compared to a non-depolarizing block, with the example here being displayed by Pancuronium. We talk about fade, so that when you give a sustained stimulus using your nerve stimulator causing tetanus, that can either remain sustained, like in a phase 1 block, in other words, there's no fade, or unsustained, in other words, there is fade, initial sharp twitch with the tetanus, and then you watch, in the case of, say, thumb adduction, you watch it start to relax over the next couple of seconds during your tetany contraction. And you'll see that both with phase 2 and non-depolarizing neuromuscular blockade. So they are both unsustained. Post-tetanic facilitation, if we give a tetanus contraction or stimulation, wait a few seconds, and then give a train of 4, you will see an exaggerated response on that subsequent train of 4 stimulation following a tetany stimulation. And that will be seen both in phase 2 and non-depolarizing phase blocks, but not with a phase 1 succinylcholine block. So spend a few minutes looking at this chart to help you understand some of the characteristic things that are pertinent to these types of neuromuscular blockades. Here's a brief summary of some of those things that we just mentioned on the previous chart. The train of 4 twitches. Again, 4 twitches at 2 hertz. Tetany is the sustained stimulus over 5 seconds. Fade is that unsustained contraction following a prolonged stimulation, like that with tetanus. Post-tetanic facilitation, increased responsiveness to the stimulation after a rest period, which I mentioned previously, that was preceded by a sustained stimulus. It's thought that this may be due to increased permeability of vesicles to calcium following that tetanic stimulation. So succinylcholine is normally hydrolyzed by plasma cholinesterase, which is circulating around, but recognize that the termination of action of succinylcholine at the nicotinic receptor is by diffusion away from the neuromuscular junction into the extracellular fluid. And this is a frequent question on the in-training exam. It's important to understand that it's not really being metabolized at the nicotinic receptor, but diffusing away. There are a couple of things that determine the duration of action when considering the amount and or the quality of pseudocholinesterase. The amount of pseudocholinesterase certainly is affected by liver disease, drugs to treat myasthenia gravis and Eaton-Lambert syndrome. Certain chemotherapeutic agents such as cyclophosphamide all can prolong paralysis after succinylcholine. The quality of the enzyme can also affect it, and there are individuals who have atypical plasma cholinesterase. They'll have a normal amount of pseudocholinesterase, but it simply doesn't work well. Both succinyl and Mivacurium are substrates for this plasma cholinesterase, and both could be prolonged in individuals who have atypical plasma cholinesterase. Recall or know that it's measured by dibucane number, which is, by its name, a local anesthetic that's not used in clinical practice other than to measure the quality of an individual's plasma cholinesterase. Normal plasma enzyme in an individual is inhibited 80% by dibucane. Atypical homozygous enzyme is inhibited 20%, and individuals that are heterozygous are inhibited 40 to 60%. Individuals who are atypical homozygous will often have hours of time following administration of succinylcholine until their succinylcholine has worn off and they're able to, say, ventilate for themselves. So here's a chart listing that. A heterozygous, the typical succinylcholine that may last 5 minutes or so is increased 3 to 4 times in the heterozygous individual. Let's look at what we mean by termination of action of succinylcholine. When you look at basic pharmacodynamics, you have a drug in a certain concentration that is free and a certain free concentration of receptor. And they must, by the law of dynamics, maintain equilibrium with the bound form of that drug with that receptor, which also is in a certain concentration. If any one of these 3 items goes up or down, the momentum of this equilibration equation shifts to the side to keep things in equal concentration. If D here is succinylcholine and R is the post-junctional receptor, as soon as one gives the drug, it's going to bind with the receptor because there's a lot of it, so it's going to push this equation to the right. to cause drug bound with receptor, which gives you your phase 1 depolarization block. At the same time that's occurring, some of the drug is percolating out, if you will, into the plasma, where it's rapidly being cleaved by pseudocholinesterase. As the concentration of drug drops from the pseudocholinesterase, in order to maintain equilibrium, this equation must move from its initial move to the right back to the left, because now this concentration is dropping. When it moves to the left, the drug, succinylcholine in this case, diffuses away, uncleaves to, and diffuses away from the nicotinic area, receptor, and in that synapse, out into the plasma, where it can try to bring up this concentration while pseudocholinesterase is cleaving it. So that gives you sort of a basic understanding of why the termination of action of succinylcholine is from diffusion away from the nicotinic receptor as its concentration decreases from rapid pseudocholinesterase activity. Let's look at some of the adverse side effects. Cardiac dysrhythmias certainly can occur with succinylcholine since they are acetylcholine-like analogs. Bradycardia, junctional rhythm, sinus arrest can all occur, particularly following a second dose. We know that these can be blunted by antimuscarinics to block the muscarinic receptor on the heart, or subparalyzing doses of non-depolarizing neuromuscular blockers can also blunt this effect. Hyperkalemia, it's important to know that a dose of succinylcholine can cause a rise of will cause a rise of 0.5 milliequivalents per liter in normal patients after IV intravenous succinylcholine. This rise is much greater in burns, denervation injury, or skeletal muscle trauma due to extrajunctional receptors. In general, you want to avoid succinylcholine in any burn or spinal cord transection, and the extrajunctional receptors start to generate in sufficient numbers after 1 to 2 days and probably reach a peak around 7 to 10 days following, say, a severe burn, in which your response at that point would be the worst, with the highest amount of rhabdomyolysis and hyperkalemia following a dose of succinylcholine. You would have to wait until a period of several months following the injury for those extrajunctional receptors to disappear. Here are side effects of neuromuscular blocking drugs. And succinylcholine can certainly have some stimulation at the autonomic ganglia, can have modest stimulation at the muscarinic receptor, causing the bradycardia that we mentioned, and also can result in an allergic response due to its minimal, although detectable, histamine release. Note that in terms of histamine, Cisatracurium certainly does have a release. Mivacurium and Pancuronium also have some histamine release. Depolarizing neuromuscular blocking drugs, side effects, myalgia, which we mentioned earlier, usually in young patients, sometimes worse in patients who are a bit maybe more muscular. They can be just undergoing minor procedures. They can return a day later to the emergency room after some outpatient surgery and feel like a Mack truck hit them, for example, and just have incredible muscle pain. We need to be attentive to this. It may relate to unsynchronized contractions to the fasciculations, but that's still not really clear. We may be able to minimize them both with pre-treatment. Certainly you can minimize the fasciculations. Unsure about whether that'll reduce myalgias consistently, but if you pre-treat with neuromuscular blocking drugs and or use non-steroidals, it can be helpful. Intraocular pressure certainly is increased, that lasts approximately 5 minutes following a dose of succinylcholine, but automatic extrusion of eye contents, globe contents in an open eye surgery have never been substantiated, and probably it's more important to secure an airway in a rapid sequence fashion if it's an emergency open globe procedure and not worry about extrusion of globe contents. It's probably also more important to minimize the Valsalva maneuver in an open eye upon emergence than worrying about the transient increase in intraocular pressure you would get from succinylcholine on induction. So this was an article 8 years ago or so from Anesthesiology that when they looked at preventing succinylcholine-induced fasciculation and myalgia, again, these two may not be linked, but there were some things that seemed to help. Administration of lidocaine, magnesium, or, as previously mentioned, that pretreatment of, say, 10% of an intubating dose of non-depolarizing neuromuscular blockers all may help blunt some of this. Non-steroidals certainly may help the myalgias. Benzodiazepines, which are great central acting anti-muscle spasm drugs, if you will, may help with fasciculations. And then interestingly, in this study, they found that a higher dose of succinylcholine was better at preventing fasciculations and myalgias than the lower dose. Depolarizing side effects, again, still we've got increased intergastric pressure. This response is inconsistent and has not been shown to increase the risk of vomiting and subsequent aspiration. There's probably increased intergastric pressure, but also some increased pressure in smooth muscle in the esophagus above the sphincter, so they may be offsetting. This can be blunted again with pretreatment of a non-depolarizing NMBD. Know and recognize that succinylcholine, along with halogenated inhalation agents, those used most commonly, sevoflurane and desflurane, and others like them, are certainly triggers for malignant hyperthermia. And then trismus, which is incomplete jaw relaxation following succinylcholine, may be seen in up to 4% of patients. It just requires a good clinical judgment because you will see it relatively commonly with an incidence of 4%. If it takes just a little bit of a delay until the jaw relaxes, that's probably of little clinical significance. If it remains sustained, though, the patient may be at increased risk for malignant hyperthermia. Some individuals in this circumstance would draw CPK and cancel the case at that point. All right, let's talk about non-depolarizing neuromuscular blockers. They generally fall in two groups, although there is a third group in development, which we'll mention. They're usually steroid molecules, and the steroid molecules can have vagolytic effects and cause tachycardia. And the one that's most prominently in that group known to cause that is Pancuronium. The other newer steroid compound neuromuscular blockers, such as Mivacurium and Rocuronium, do not seem to have that side effect. The other type of chemical structure are the benzyl isoquinolones, of which Cisatracurium and Cisatracurium are the most prominently known in those classes. And these types of chemical structures are more associated with histamine release. Cisatracurium certainly caused histamine release. Its cis isomer was developed primarily to prevent that effect. These are quaternary ammonium groups. They're ionized, highly water soluble. They certainly can also work in conjunction with and enhance neuromuscular blockade by halogenated inhalation agents. And as mentioned, their cardiovascular effects may be exerted through both muscarinic and histamine effects. They, as a class of drugs, are most commonly associated with, of all the drugs we use, with measurable anaphylactic and anaphylactoid reactions. This is another look at that same table. We've talked extensively now about succinylcholine. We're now going to consider some of the non-depolarizing agents over here. including Ganticurium, which we will mention also, which is the newer short-acting non-depolarizing agent. Know that this is a table out of an older edition of Morgan and McCall. There are a number of drugs that are given by us and or our physician surgical colleagues that can affect our depolarizing blocks. Most prominently, we know that a number of antibiotics can potentiate both depolarizing and non-depolarizing blocks. Lasix can affect depolarizing blocks in low dose, but seems to be perhaps protective in higher doses. Things like lithium can prolong and onset the duration of succinylcholine, and its effect on non-depolarized is unclear, but certainly there is a case report of it. So spend a bit of time looking through this. We know our colleagues up in the obstetric area, when using magnesium sulfate in the management of preeclampsia, again, another drug that can potentiate both a depolarizing and a non-depolarizing block when given. So non-depolarizing neuromuscular blocks, they are potentiated also by hypothermia, hypokalemia, hypocalcemia, or respiratory acidosis. Whereas burn injury with the extrajunctional receptors, unlike with succinylcholine, which can cause a dangerous hyperkalemic response, because of these extrajunctional receptors, patients are usually resistant to non-depolarizing muscle relaxants, so the dose would have to actually be increased. And that may also be true in individuals who have had a stroke. The bottom line is you need to monitor your response with a nerve stimulator. Recall that when using a nerve stimulator, the black lead goes over the nerve. Typically that's usually either the ulnar nerve on the wrist or just lateral to the eye over the orbicularis oris, and then the red lead is the ground and can really go anywhere else on the body. Some of the diseases with altered responses to muscle relaxants. Spend a little bit of time with this. Know that in something like Guillain-Barré, they're going to become hyperkalemic with a depolarizer, but they would be sensitive to a non-depolarizer. Disorders like myasthenia gravis, they are resistant to typical effects of depolarizers, but they may have an increased response or an increased likelihood to develop phase 2 block, which again, phase 2 block is much like one would see with the non-depolarizers, so they're actually hypersensitive to non-depolarizers, and you'll see a similar type of situation in myasthenic syndrome as well. Of interest to patients that we sometimes provide anesthesia for at the Shriners Hospital, individuals with cerebral palsy, which is a sort of a fixed central muscle disorder, can safely be given succinylcholine with no hyperkalemia. This is also true of individuals with myelodysplasia, spina bifida. So the succinylcholine can safely be given with no concern for a hyperkalemic response. And then different from that, though, is in Duchenne's muscular dystrophy, rhabdomyolysis, and an increased potassium are a risk. There's still some debate over whether this response typically is not malignant hyperthermia, and this disorder is not associated with malignant hyperthermia, unlike some other muscle myopathies like central core disease, so that MH is typically not considered to be a risk in Duchenne's muscular dystrophy, Even so, they should not be given succinylcholine. So let's look at some of the drugs. Pancuronium is inexpensive, long-acting. There's a greater risk of it hanging around for a long time. One can be confused into thinking that a patient is completely reversed from a neuromuscular blocker. And this is the concept of spare receptors. You can ask them for a sustained head lift, for example, or look at the train of four. And if it looks normal to your eye, they can still have 30 to 40% of their receptors bound. And that can be protective, the concept of spare receptors, but in our clinical practice, it's probably more commonly a concern. And the reason why most people would argue that it is routinely recommended to reverse these patients. The concern is that if it looks good to you, you don't reverse them, and then they go to the recovery room and say they have a little bit of hypokalemia and they have some opioids on board and they get a respiratory acidosis. Those things can potentiate neuromuscular blockers, and since already 40 to 70% of their receptors are covered, they will relax in the recovery room, which, if unrecognized, will cause swallowing difficulty, silent aspiration, airway obstruction, hypoxemia, ultimately respiratory compromise and/or arrest. Remember that we mentioned pancuronium has a vagolytic effect and therefore can cause tachycardia due to its muscarinic blockade. Vecuronium has to be reconstituted. It's a mid-range acting length, unlike pancuronium. It does undergo biliary excretion, primarily some liver metabolism and 25% renal excretion. Recognize that when given long-term in the ICU, it certainly can result in prolonged blockade. I don't think it's used very often due to that problem. Rocuronium is the drug that we're most commonly familiar with. It was an important addition to the class of non-depolarizing neuromuscular blockers because of its rapid onset. And that is an important contribution of this drug to this class of drugs. It's intermediate acting, eliminated primarily unchanged in bile, but up to 30% undergoes renal excretion. Cisatracurium is the benzyl isoquinoline, which is the cis isomer of atracurium. Atracurium and cisatracurium both undergo two types of metabolism: hydrolysis by non-specific esterases, and then Hoffman elimination, which is an organ-independent degradation that occurs spontaneously in the plasma, but is dependent on normal pH and temperature. It's important to remember then that if a patient is extremely hypothermic, the length of time of cisatracurium can be significantly prolonged. So for both cisatracurium and atracurium, the byproduct of Hoffman elimination is laudanosine, which can cause seizures via CNS stimulation if it develops in higher doses. Cisatracurium, unlike atracurium, does not cause any clinically significant histamine release. Because it undergoes elimination that is organ independent, it's a good drug to use in people with impaired renal or hepatic function. Mivacurium, for historical interest, very short acting. Its production was discontinued probably just from low demand because it was not really a dangerous drug, but it just was not used that much, and it made no sense to continue producing it because it wasn't used that much. It has a longer time to onset compared to Cisatracurium, uh, but it is quick off and acts for a relatively short period of time. It can cause histamine release. It's metabolized by pseudocholinesterase and also by true cholinesterase at the actual, in the folds at the synapse of the nicotinic receptor and on the muscle membrane. But it was a good drug for quick, highly stimulating cases such as foreign bodies in the airway or the esophagus, where you needed a fairly deep, still field for them to remove the object, but the cases were quick and there was really no closure time for suturing or anything in these circumstances. So it became a good drug for those types of cases, but is no longer in production. And Rapacuronium, short-acting, rapid onset, undergoes hepatic metabolism with renal excretion. It was removed from the marketplace over 10 years ago. It was felt that this drug bound with a higher affinity to the nicotinic acetylcholine receptors in such a fashion that it left acetylcholine receptors in the lung more vulnerable to be bound, which can cause bronchospasm. So there were a couple of case reports of severe bronchospasm that resulted in death, and for that reason it was removed from the market back in 2001. And then the new kid on the block, so to speak, Ganticurium, is in development. It would replace drugs like Rapacuronium if in fact it follows and passes FDA certification. It is a very quick onset, less than 90 seconds, with a short duration of action, and it also, like Cisatracurium, undergoes organ-independent inactivation by the ester hydrolysis and then also cysteine adduction. And in fact, although I can't think of many instances where you'd want to do this, but you can shorten its duration of action by administering IV cysteine. Higher concentrations of this drug can also release histamine and cause tachycardia and hypotension. So we'll have to wait and see what happens with this drug. It's in development. You may see it in your practices in the coming years. And here is a summary chart out of an edition of Stolting's Basics of Anesthesia that gives you some of the doses, the time of duration to at least 25% recovery, which is, you should wait for that. That'll be covered in another lecture in this block. You should wait until that degree of recovery before you reverse. What's the intubating dose, continuous infusions, and then some of the pharmacology, pharmacokinetics that would be important to the different drugs. And then finally, one can hasten, and this was mentioned before earlier, the onset of a non-depolarizing block to about 90 seconds by using a priming dose. So if you wanted to hurry your induction, so to speak, you could give a 10% subparalyzing dose of say rocuronium, followed 4 to 5 minutes later by the full intubating dose. Recognize that this priming dose, however, can cause muscle weakness and patient anxiety, and you need to be ready to induce if and when that occurs. And this typically is a nice way, though, to hasten the onset of the neuromuscular blockers, non-depolarizers. And that concludes the podcast on basic pharmacology of neuromuscular blocking drugs.